Yes, one. Yes, one.
Check, check.
You have to, Good morning. Can everyone please start taking their seats? So, if I can ask for quiet, we are going to be broadcasting this live via the web, so what you say now can be heard. And a welcome to our audience online. My name is Dr. Philip De Croo. I'm working the Manson unit with MSF in London. A warm welcome to all of you here today. This is the MSF Scientific Day South Asia, and it's a very exciting time. As many of you can see, I've been given a very special outfit. A friend gave it to me, and I got very excited when I saw it because I thought, wow, I'm being invited to a wedding. You know, it's something really important. But then the person said, well, actually, you're emceeing the MSF Scientific Day. And actually, if it's a wedding, it's going to be a little bit more fancy than what you're wearing. Actually, I think that's kind of appropriate because some of the research that MSF does, it's maybe not the most expensive garment in the shop. And one of the reasons why we hold this day is because we want to discuss the research that MSF does to try and make it better. So I really encourage you, if you're online, to be writing comments, to join in the discussion. And for those of you here also, we really welcome your questions. I do have a poster that I have borrowed from online, which gives a guide to asking questions. I do encourage you to read it. While it is slightly tongue-in-cheek, it does make the point that since we're limited for time today, please introduce yourself when asking questions. Please say which organization you're with and ask a short question. There will be time in the breaks and lunchtime for lots of discussion. We're not asking you to give a long opinion about things. We want to hear from the speakers and ask them probing questions. When I thought about this and thinking about it being possibly like a wedding, I realized, like all MSFs, it's much more like an emergency than a wedding. As you can see, we're starting late. People are still filtering in. The instructions are there, but maybe some of us, like the MC, haven't read the instructions. So I thought when it's an emergency, we should turn to that instructional book from MSF about what are the priorities in emergencies. And it's important that we're all on the same page about the priorities. And of course, in an emergency, the priorities are water. It's a very hot day. There'll be plenty of water provided upstairs and hopefully at the back of the room later on. Keep yourselves hydrated. Food. We'll be providing plenty of food during the breaks, so don't panic. There's very good food. It will all be upstairs in the room above us. Sanitation. If you need to leave during the session, no problems. Just go upstairs and on the right you'll find the bathrooms. Coordination, that's my role. I'm going to be trying to keep everyone to time. The first session is it's two topics in one without a break. So please bear with us. There will be plenty of time for breaks, but try not to introduce your own breaks. Also, we will have some surveillance, or at least what I call surveillance. Please do, if you have a phone, try and follow the online discussions and join in. If you're tweeting, then please use the hashtag MSF-SciSA, which is in your notes. And there's a comments box on the live stream, so please use this as well. So, finally, why are we here? We're here, I think, primarily to take a chance to look at the medical work that MSF does and the evidence behind it. Quite a long time ago, I was privileged to start one of the first MDR-TB patients on treatment in one of MSF's programs here in India. And I think of that patient, he was a patient who had HIV. He was a patient who had suffered from stigma and wasn't allowed into many of the clinics around that program. He was a patient who'd been treated for TB and had paid in private clinics to the point of having no money left. He was a patient living at home with his family who didn't know that they could be acquiring what was drug-resistant TB from him. That was a patient who had a body mass index of 13. And the program had never treated drug-resistant TB before. We managed to start the treatment. The patient had many side effects, but eventually there was some successful outcome. But what I like about these conferences is it's a chance to say, well, why is that patient the minority? Because today, with MDR-TB, with many of the problems we will talk about today, access to the right treatment is actually only for the minority. And this conference is about bringing evidence to improve access to care. But secondly, when we provide that kind of treatment, like we see with many diseases, like the treatment we've had with leishmaniasis for many years or African sleeping sickness, we actually have tools that are not fit for the job. And it's research that highlights that and helps us call for better tools, more investment into research to bring better tools. I think today also reminds us that behind every topic like antimicrobial resistance or infectious disease or whatever title we put on a session, there is a patient, actually hundreds of patients, thousands of patients. And as we are hearing the presentations today, the panel discussions, I want you to be challenging and asking each of the presenters, but how does your research make a difference for a patient or for a program? This is about debate, taking evidence to make a difference for people and patients. Because the situation where people can drown in the sea, not that far from where the most powerful leaders in the world are meeting, and nothing really is said about it at that conference. The situation where people in Syria continue to suffer from attacks from weapons which nobody thinks should be used in any war. The situation where there are so many people who are denied passage to be able to flee from conflict or persecution, and those situations occur around the world. MSF is about Doctors Without Borders, and fundamentally it's about a helping hand for people, whether that hand comes from medical care or changing policy or bringing attention. So with that little sermon out the way, I wanted to move on to our first session, and I'll invite Dr. Uni Karunakara up to speak to us. His bio is in the notes, more than 2 decades as a humanitarian and a fellow from Yale. Thanks, Uni.
Right, thanks, Philip. Philip and I are going to be co-teaching a small course in a few weeks, so I can see how this is going to go. You're going to be taking over my time, and I get very little time to speak, so it's good to know that. So, welcome everybody. I won't take too much time. We launch into the first session on a very important topic, antimicrobial resistance. MSF today, Médecins Sans Frontières, as a global medical humanitarian organization, we provide care in close to 70 countries around the world. Last year alone, we had more than 8 million OPD consultations around the world. So you can imagine it's a large number. And in almost all of the places where we work, we are now seeing resistance to very common antibiotics. And this is very worrying. But resistance is not a new thing. We've been dealing with resistance to antimalarials. We've been dealing with resistance to TB drugs. We've been dealing with resistance to in diseases like sleeping sickness, Kala-Azar, etc. So this is something now which is being taken more seriously globally. Just to give you an idea, between 2000 and 2010, the global consumption of antibiotics went up by 36%, and 3/4 of that in BRIC countries, where regulations for the use of antibiotics and the use of antibiotics tend to be very lax. And compound this with lack of proper hygiene in hospitals, lack of diagnostic facilities, diagnostic tools, we have a very dangerous situation, and resistance is growing. But it's not just the use of antibiotics in humans, it's also the use of antibiotics in animals. So for example, 2/3 of all of the world's antibiotics are used in livestock, and not necessarily to prevent infection, but to promote growth. So we really need to we cannot look at the use of antibiotics in humans alone without looking at the use of antibiotics outside the human population. Now, more broadly, research, development, and production of new drugs today depend on a system that reflects high prices and monopolies to pay for innovation. We have an intellectual property system, we have a drug development system that a lot of people believe are not fit for purpose, not the one we would want to have if we are to have new drugs, new therapies for infections for the future. We will go into all of this. We have 3 panelists who will discuss some of these issues with us today. But before that, we have 2 presentations. The first presenter is Tambri Housen. You have, I'm not going to go into the bio, you have the bio in your packet. Now, 10 minutes, and we are going to take questions directly after the presentation. After both of the presenters are done, we will invite the panelists onto the stage and we can have a discussion. So, Tambri, yeah, you have your slides there?
Okay, so good morning, everybody. Sorry. Today I'm presenting the results of an investigation of reported increase in mortality due to neonatal sepsis in a neonatal unit that MSF runs in Quetta, Pakistan. And what we found is that it was a case of antibiotic resistance. So to provide some background, MSF works in Balochistan province of Pakistan, which is the light pale colour there. They work in 3 districts, working in mother-child healthcare. Balochistan has the worst health indicators for the whole of Pakistan, with very high maternal mortality and infant mortality. MSF established a paediatric hospital in 2011 with 60 beds, 20 beds of which are part of a neonatal unit. MSF also have a mother-child health clinic, which is about 20 minutes from the hospital, providing basic emergency obstetric care and outpatient care for children under 5 and treatment of other conditions. So the paediatrician in the team in the neonatal unit in Quetta raised concerns that there might be an outbreak of neonatal sepsis, and they also raised concerns that they felt there was growing resistance to the current treatment protocols. So in response to that, we analysed routinely collected clinical data with these two questions in mind. Is there an outbreak of neonatal sepsis in the neonatal unit? And what are the causative pathogens of neonatal sepsis and their resistance profiles? So just for everyone to realise, neonatal sepsis is defined as bacteremia or bacterial meningitis that occurs during the first 28 days after birth. Early onset sepsis occurs within 72 hours, and late onset sepsis occurs between 72 hours and 7 days. So the case definition adopted by the team is the OCB case definition. And as can be seen here, there's many symptoms, and the case definition is very broad. So in the presence of one of these danger signs, or in the presence of two of these danger signs, a neonate is classified as having neonatal sepsis. The case definition is very sensitive, but not very specific. At the time we conducted the analysis, the treatment protocol was in line with the WHO treatment protocol and based on the MSF 2013 neonatal guidelines, and included ampicillin and gentamicin for at least 10 days, and if a staphylococcus infection was suspected, cloxacillin and gentamicin were used as first-line treatment. After 2 to 3 days, if there was no response, the second and third-line treatments incorporated the cephalosporins. So we conducted an analysis, a retrospective analysis of routinely collected data. The neonatal sepsis line list had been established in February 2016, and a suspected case of neonatal sepsis was one that met the case definition. Antibiotic resistance profiles were also recorded in the line list. Antibiotic susceptibility testing was conducted using the disc diffusion method at Aga Khan University Hospital Reference Laboratory in Karachi. The MSF laboratory advisor had visited the laboratory at the end of 2015, conducting a quality assessment, and the two dot points there show the quality assessment tools she used, and she found that the lab met all the minimum standards well above what was required. So data was analysed from February 18th to July 14th, and it was exempt from ethics review as it was a retrospective analysis. So the characteristics of our neonates: out of the 274 neonates that were admitted to the unit during that time period, 98 met the case definition for neonatal sepsis, 70% were male, 60% were classified as having low birth weight. The median age at birth was 38 weeks gestation, and the majority of the neonates had early onset sepsis. So where did they come from? 10% came from the MSF facility in Kuchlak. 26% were home births that had presented at the emergency department at the hospital, and 64% had been transferred from another health facility. So not to get overwhelmed by this graph, it's basically just to show the diversity of pathogens that were highlighted, that were isolated rather. The graph shows all of the cultures, the bloods that had been sent for culture from the neonates during that period, with week 7 being the middle of February and week 28 being the middle of July. The dark greys show that out of all of the bloods that were sent for culture, the number of culture results that did not come back to the unit, that were not reported. The light grey shows the number of cultures that reported no growth, and the colours show the different pathogens that were isolated. And for those of you that are familiar with your bugs, you'll see there's a mix of gram-negative and gram-positive bacteria. The red line represents the case fatality rate, which, as you can see, is not consistent during this period. It's kind of all over the place. So there were 97 blood cultures sent, of which 43 there were no results reported. 55 we had results for, of which 22 out of the 55 were culture positive. So of these 22 culture results, we had 13 that were gram-negative bacteria. Nearly half of these were Klebsiella. And as we can see from this graph, there's a very high resistance to ampicillin and gentamicin and to the cephalosporins, with sensitivity to amikacin, imipenem, and piperacillin and tazobactam. So the grey represents susceptible, the green intermediate resistance, and red is resistant. Out of the 22 isolates, 9 were gram-positive bacteria, and of concern here was the majority of which was Staphylococcus. The concern here was that 7 were oxacillin resistant. So the limitations we faced is that infection control could not be assessed and blood collection practices could not be assessed. I was unable to visit the unit in Quetta. Data was incomplete. As we discussed earlier, the diagnosis of sepsis is based on a syndromic case definition, meaning it's very broad, so many of these babies may have been misclassified. 30% of neonates had already received antibiotic treatment. There were missing lab results, and the sample size of our positive results was very small. However, relevance to practice is that we did identify multiple pathogens. There is a high risk for outbreak, and therefore it's imperative that infection control guidelines are strictly adhered to in the unit, and that there's regular monitoring and evaluation that these guidelines are being put into place. There's also a need for review of the treatment guidelines. So results are consistent with other studies. So even though we had a very small sample size of 22 isolates, they are consistent with findings in the scientific literature. One that I want to highlight today is a study conducted by Salim in 2013, which looked at neonatal sepsis in a neonatal intensive care unit in the Aga Khan Hospital in Karachi in Pakistan. And of 104 Klebsiella pneumonia isolates, over 80% were resistant to ampicillin, gentamicin, and the cephalosporins. So the translational action that came from this analysis was that treatment protocols were changed in February 2017. There is a need for antimicrobial stewardship policies and advocacy for the implementation of these policies. There's a need for continual staff development in this area. There is a need for regular surveillance of AMR to monitor changing patterns over time. There's a need for regular review of scientific literature to also recognise findings from others who are conducting studies in these areas, and a regular review of treatment protocols. There's also a need for strengthening of laboratory capacity in order to ensure that we get timely results that we can act on. So the question I'd like to leave with you today is, are the days for universal treatment protocols over? I'd like to acknowledge the team that were involved in this study and leave you with the references that I mentioned earlier. Thank you very much.
Great. Tambri, thank you. So quite a concerning sort of study. We'll have another study presented from India by the next speaker. Any questions? While you think of your questions, I have one for you. The last question that you posed, universal treatment protocols, are the days over? And one of the ways we increased the quality of the care that we provided in MSF was by introducing standardized treatment guidelines and protocols. So how would we sort of tackle this in the future, where you have to personalize treatment? How would that work? Any thoughts on that?
Well, from my side, I think, especially in today's landscape of growing antimicrobial resistance, and with neonates, they don't have a lot of grace and a lot of time. So we need to make sure that whatever treatment we give, they respond to straight away. We don't have time to play around and change with antibiotics. So I think now, just with the changing climate that we have, it's just imperative that we strengthen lab capacity in all the areas that we work, so that we can actually do antimicrobial testing and do it regularly. Not that we have to do it all the time, but during over a time period to monitor changes so that we can adapt, because regionally it does change.
We've done that in tuberculosis to some extent, and hopefully we can do that for common infections as well. There's one question from our online viewer.
Hi. So the question is, are the days of universal treatment protocols over? That's one of the questions which has been. asked by our online viewers.
You're asking it back to me?
That's the question that she posed as well. Just say that the presenter agrees.
I might leave that question for the panel to discuss.
Yes, there's someone in the back. Please state your name and where you're from, and then ask the question.
Hi, I'm Dr. Shomadip Bhaumik. I work for the BMJ Global Health and also for the Public Health Foundation of India. So it's regards to what the question you asked, and this was one of my dissertation topics I had done. So I think one of the key issues with clinical practice guidelines and protocols is also to monitor and evaluate them, how relevant they are. So I think the answer to your question is that we need to check how the protocols are relevant to it and to be able to modify them, because clinical practice guideline can improve the quality of quality of care only if its quality is good enough for that purpose and that context.
All right. So that was a common, lesser question. There's one person.
It's a comment and a question.
State your name and where you're from, please.
So I'm Jyoti from Center for Disease Dynamics, Economics and Policy in South Asia office. And my question is, clinicians and lab, they generally don't tend to work together. So one, the question is, what was the practice in your region? Like you send the samples, reports came back, but is there consultation? Because surveillance and treatment protocols need to be devised together. Unless it's done in sync and constantly monitored based on the practice, it's no longer going to be relevant. So what was the practice and how was it taken about?
Okay, I will take the liberty of answering this question, although I'm not from Quetta. So the Quetta team, please forgive me if I misrepresent anything. But from my understanding after talking with the team is that from Quetta, the lab results get sent. There is an Aga Khan laboratory reciprocal next door. They take the lab results and then send them on to Karachi, where they're analysed. And this link is now being strengthened. So MSF have now implemented a new position in Quetta as a laboratory support person, and they're now making stronger links and stronger efforts with the Aga Khan laboratory in Karachi, with the plan of implementing regular surveillance, where every neonate that's admitted to the unit is swabbed and samples are sent to look for the pathogens that are actually highly prevalent in the unit. So this is something that the team have recognised is important, that communication with the lab, and now they've made efforts to improve that.
Yes.
Morning. Thanks for a very good presentation.
Please state your name.
Yeah, I'm Dr. Ashara from SGBV team, Delhi. So my question is, there are 26% home deliveries and 26% home deliveries sepsis and 10% from MSF facility. So where went wrong in the MSF facility? Because you follow international standards and all. And at the same time, actually, antenatal checkup, whether you screened whether mothers had any infection, so resistance, whether during antenatal period, mother took any antibiotics or screened for any genital infection. Was there any, to have any guidelines?
One thing I probably failed to mention in the beginning, I think, is that 70% of all births in this province of Pakistan are home births, and women receive no antenatal care. So some of the women that come to the Mother-Child Health Service in Kuchla are coming when they're delivering. So some of them, many of them would not have also accessed antenatal care. So as far as the 10% that came from the MSF clinic, I don't have the authority to answer that. I'm not sure, but I couldn't even hypothesize. Sorry about that.
Yeah.
Thank you.
We'll take one more question and then we'll move on to the next presenter. Anyone? All right. In that sense, I will invite the next speaker to.
Thanks.
Thank you, Tambri. Thank you. Where's the next speaker? Oh. Okay, he's hydrated. All right, great.
Good morning to all. My name is Dr. Valay Ashara. I work as a medical doctor in the Asansol project, MSF India, West Bengal. So today I'm going to present a prescription audit that MSF staff did on the local doctors in Asansol. To tell you something about Asansol, it is 220 kilometers from Kolkata and second largest city of West Bengal. There are a lot of coal mines and steel plants in that region. This is one of the villages shown in that coal belt. You can see the location. From the data gathered, there's about 0.5 government doctors per 1,000 residents. Right now, MSF is based at 2 sites, district hospital and one of the primary health center. I'll tell you something more about the sites. So both are outpatient clinics and work from 9 a.m. to 1 p.m. apart from Sundays when they are closed. The patients who want to see the doctor are given clinical notes and they are allowed to keep it after the consultation is done, and that is the only form of data that is there. The clinic in the district hospital is outpatient pediatric clinic with one Ministry of Health pediatrician and one Ministry of Health pediatrician board trainee. They see about 110 patients per day. There is an X-ray site available, X-ray on site available. Something about the primary health center. There's one Ministry of Health general practitioner or medical officer who sees all age groups there, and they see about 225 patients per day. There's no X-ray at site available in the primary health center. Right now, MSF is working to treat acute respiratory illnesses in the pediatric population, and we are also learning about antibiotic resistance in the Asansol region alongside with the Ministry of Health. So in December 2016, our project was concerned with fever in the pediatric group of populations, but later it was decided we will open respiratory illness clinics and to understand more about the antibiotic resistance in that area. So we wanted to learn about the baseline practices of doctors in that particular region, and that's why we did this audit. So we want to actually see the prescribing practices of pediatricians in the district hospital and general practitioners in the primary health center. Diagnosis made, prescription format and other medications prescribed were a few of the parameters that we studied, but today I'll try to concentrate more on the antibiotic prescription patterns. How did we do it? So it was an exit survey over 2 weeks. So first of all children who wants to see the doctor would come across MSF staff who, if they meet the criteria, I'll talk about criteria later. Later on, the nurse will put a symbol on the prescription paper, and the child is allowed to see the doctor. After the exit, they again come across another MSF staff who actually takes a picture of the prescription, and the data is extracted, entered into a spreadsheet, and then the photo is destroyed. About the inclusion criteria, like I mentioned, the age group that we decided was 6 months to 12 years. This is as per the agreement that we made with the local authorities, plus any of cough, sore throat, runny or blocked nose, difficulty breathing, ear pain, discharge. Any patient with fever or history of fever was excluded from the study, because like I said, this was done in December 2016, where we were seeing fever in the pediatric population. So anyway, any patient with fever saw a MSF doctor, so they were not part of the study. To tell you something more about the photo that we took, parameters like age, assessment, diagnosis, medication, duration were taken, and later on, like I said, the photo was destroyed, and this was after taking proper permission from the authorities. So these are the results that we came up to. We saw about 268 patients, 201 in district hospital and 67 in the primary health center. The mean age of the patients was 45 months in the district hospital, while it was 40 months in the primary health center. So 61% of patients were prescribed antibiotics in the district hospital and 67% in primary health center. Mind you, these are the patients that were without fever. One of the very striking difference between the two clinics was that 75% of patients were recorded diagnosis in district hospital, and in the primary health center there was no diagnosis recorded in the prescription paper. It was only the medication that was given. Indicators of severity of the patient was not documented in any of the clinics. These are a few more things that we concluded. The mean antibiotic duration at the district hospital was 5 days and 3 days in the primary health center. Non-pharma advice like steam inhalation, hot fermentation, hydration was about 20% in district hospital, while only 4% in primary health center. Generic antibiotic prescriptions were about 83% in district hospital and only 13% in primary health center. Doctors followed a standard prescription format in 95% in district hospital, while it was very less, about 13% in primary health center. The most commonly prescribed antibiotic was amoxicillin and clavulanic acid in the district hospital, and in the primary health center it was amoxicillin. This was the graph that we plotted. That's the antibiotic given against the diagnosis made. There are a few important things seen from this graph. As you can see, anyone who were given diagnosis of common cold were not given antibiotics. On the other hand, any patients who were given the diagnosis of lower respiratory tract infection were given antibiotics, all of them. As you can also see that many patients who were not given any diagnosis, and a large portion of such patients were given antibiotics. When they made a diagnosis, it was something like RTI, which is respiratory tract infection, which in itself is a very non-specific diagnosis again. And as you can see, a very large portion of patients received antibiotics for that. So this is the desk of one of the doctors in the government hospital. We can see a lot of medical literature from the medical representative, and we all know that this is forbidden, but it still happens. We shared our findings with the local health authorities, and the head of Department of Pediatrics at the district hospital was happy with the first step that MSF took for antibiotic stewardship, but he was not sure how he can help further. The chief medical officer at the primary health center was surprised that the diagnosis was missing from the notes, but was on the other hand happy with the antibiotic prescription rate. What did we learn? Like, it was easy to do this study. The patients and the local doctors accepted the technique. The limitations of this study are that it is actually difficult to comment on the appropriateness of antibiotics, as very limited information is given on the assessment of the patient and the clinical diagnosis made. It was a point prevalence audit within a very short time frame, only 2 weeks. So there are ongoing discussions with the local health authorities there on how we can take this cause further, how we can decrease the antibiotic prescription rates. And there are some talks that we make treatment guidelines and offer it to the doctors after the local consensus, but how it will actually help the local authorities and doctors is yet to be determined. So since last few months, we have opened a respiratory clinic, and this is one of the problems that we came across. And it was that the patient themselves, they actually expect a longer list of medications in their prescription papers, and we are trying to find a way around it. In summary, in this prescription survey, it can be said that 61% and 66% of children with acute respiratory illness were given antibiotics, and these were the patients who were without fever. Limited documentation on outpatient clinical notes was very common, like I discussed, and carrying out the survey was acceptable to doctors, patients, and caretakers. So this study was not possible without help from my team back in Asansol. Thank you very much for listening.
Okay, thank you, Dr. Ashara. Prescription analysis is a simple but very important tool to understand the prescription habits of doctors, but also this is a very worrying study. It gives you a sense of what is not being done right. Questions? Person there.
Hi, thank you. I'm Jyoti from CDEP. Thank you for that study. It was a very small but very informative study. I think it also points, like you have said, about two important areas. Though in clinical practice, viral infections that happen quite a lot tend to be given antibiotics, which is irrational use. So that is where stewardship with the medical college and the clinical practitioners will help. But also a fact that comes out very clearly from your study is the demand for antibiotics from the community, or not knowing the need for the antibiotic in case of anything they suffer. So besides, I think, doing stewardship programs with clinical facilities, it's also important to do advocacy with the public and the common man who's entering clinic, that, trust the doctor, or do not ask for antibiotics unless you are being prescribed, and don't insist on it. Or if you have been prescribed an antibiotic, double check, because there are long-term implications like we are discussing today for livestock, for human health, and with binding pipeline, it's not needed. So I think we are doing a lot of work with the health facilities, and that's really good. But at the same time, there's a lot of need to educate the common masses on the nature of this epidemic which is impending.
Very true.
So did you do anything of this sort?
Actually, yes, we try to educate the people during consultation all the time, and we have our communications team who is working very hard against this. We give a lot of advice, non-pharma advice that can help them with the disease when it's acute, and then the symptoms will eventually subside. So yes, we are actually trying a lot to make the people understand the importance of not taking an antibiotic when it's not required.
Here, there's one question.
Thank you, Doctor. I'm Jyotsna Puri. I'm with the Green Climate Fund. So I'm a non-medical doctor. For me, what came out really interestingly was that there was such a stark contrast between the practice at the district hospital and the primary healthcare center. And I was wondering whether you'd seen it in other cases and systematically as well. Because I noticed that in your list of next steps, I didn't see you thinking about perhaps investigating this divergence across other sites, and then trying to see as to whether this was also well, first, of course, explaining the difference between the two, between the district hospital and the primary health care center, but then also seeing whether this was systematic and whether if you could find a systematic difference, then what conclusions you could get for policy there.
And don't forget the private healthcare providers. We haven't even talked about them in the district.
Yeah, sure. I mean, like I said, there is a very big difference between the district health and the primary health center. And we have talked about the authorities who are in the primary health center, why such difference is there. One of their concern is the less number of doctors that are there at one time. So they see, their actually excuses, like they see about 225 patients in 4 hours, and with only one doctor there at one time. So that was their excuse, that it's really not possible to assess all the patients and write all the clinical notes for each and every patient, for they have to see a lot of patients. I don't know. Yeah.
Okay. 1 second.
Yeah, please.
I'm Ankur from University Research Company. So I had a small question. Was there any difference in terms of the profile of the doctor or doctors in two facilities, in terms of their specialty or experience?
Yeah, like I said, in the district hospital, there's one consultant pediatrician, and there's his helper, his pediatrician board trainee at one time. While in the PHCs, it was one medical officer who is a general practitioner and sees all age groups at once. So that's how it happens. Yeah.
So, and he's a doctor, MBBS doctor. All right.
Yeah, I'm Dr. Santosh from SARA board. Just one question is like the 61% and the 67% of the both groups were prescribed antibiotics. That's the only finding. But how would we arrive at a conclusion that these were are we going for the conclusion that these prescriptions were irrational? Because we don't have any tools of knowing that even the 61 or 67 person had a bacterial load. So, so how are we actually going to direct this to a conclusion that if is there a rational practice or not? That's how.
I understand, and actually that is one of the, like I mentioned when I was giving the presentation, this is one of the limitations of the study. Because from whatever information we have from the clinical notes, not enough data is actually there to say that this is or not an appropriate antibiotic prescription. But it is safe to say that there's a lot of clinical data that is missing from the clinical notes.
Sure. We'll take one last question and then we move on to the panel discussion. Suman?
Yeah, I'm from DNDI. I'm Dr. Suman Rijal. Thanks for your presentation. I just wanted to share with you that there are multiple factors that can play a role in these prescribing habits. And some of them are very obvious. As you mentioned, they've got the load of the patient, number of patients they have to see. But then I think recently we have been hearing a lot, especially from West Bengal, of defensive medicine because of the hyper sensitivity of the population to incidents where sometimes you have morbidity, mortalities which are quite obvious in some instances. So doctors are doing defensive medicine. And there's another issue I would like to also bring to the thoughts for some thoughts is we have to see how we are training our graduates. What I can see are medical graduates. Because most of the times, as you see, they're exposing them to tertiary care hospitals, we are exposing them to inpatients, and very little exposure to working in the PHCs. So I think there is also a fundamental lack of experience on, especially in the PHCs. When you send doctors after they are recruited, and they do have very little exposure in managing patients at such limited, because the type of patients which will present to you, PHC and hospitals, are quite different. Right. So this is from my experience from my previous job, that we see that there is a difference when you train them in the different ways. This is just some comments.
I mean, it's really a valid point from your side. And the doctors have actually also said, and we have experienced quite sometimes aggression from the patient side if something happens to the patient. So sometimes the doctor actually replies by saying that we can't take chance. If the patient is really far from the primary health center or district hospital, and if it's very difficult for him to come when the situation rises, it can be very difficult for the patient in general, and so they prescribe the antibiotics that they do sometimes.
Okay. Thank you, Valay. We have to move on to the panel discussion. So what we've seen are two snapshots, one from Pakistan, one from India. These studies in itself are not enough to change, sort of establish new protocols, guidelines, etc., but they sort of tell you what the trends are in the field, in practice, in patient prescription habits, but also the consequences of those habits, long-term consequences by increasing resistance. So thank you, Dr. Valay. Thank you, Tambri. Thank you for the presentations. And we'll now move on to the panel discussion. Okay, great. So now I have the pleasure of inviting three panelists to the podium. We have Dr. Alan de Lima Pereira, if you can join us. We have Dr. Surendra Wong and Dr. Philip Matthew. Yes, okay. Thank you for joining us, Dr. Matthew. So just a brief introduction. Alan is a doctor from Goa and has worked with MSF in several missions. He's seen firsthand the consequences of antimicrobial resistance in many, many countries. We have Dr. Surendra Wong, who's an epidemiologist from France, also an old MSFer, and now with WHO in the South Asia office here in Delhi. And we have Dr. Philip Matthew, who is the director of REACT. Yeah. Who is an organization that works on AMR. So, Alan, if I may, I'll start with you. Perhaps you can paint a picture. You've seen the two presentations. Perhaps you can paint a picture of what you're seeing on the ground as far as your ability as a doctor to effectively treat patients, from infections.
Thanks, Suni. Yeah, I think the first two presentations were a really good example of what we see as MSF in the field, and I think me and a lot of people who worked with MSF can say it's quite common in most of the countries we work. We've been using quite broad spectrum antibiotics and for common syndromes, and not tailor-made for certain, like we said, based on resistance patterns or local sensitivity patterns. This has helped us, like we said, improve the quality of care and respond fast in the places we've been working. But now we've been seeing resistance developing, and we have, in addition to the examples that they already gave, surgical projects in Jordan treating osteomyelitis, which are resistant to most antibiotics. So we have experience, I think there's been some studies in Afghanistan as well, which show huge numbers of antibiotics used. So we definitely see that as a problem. I think one of the things we've really had difficulty in scaling up or have difficulty is in access to bacteriology labs. This is still not standard practice in most of the places we work, and the turnaround time to get a sensitivity result to tailor-make your antibiotic per patient is still too long in most places where people don't have, and people and healthcare providers don't have access to this. The next challenge we see, or a need we really see, is point of care tests. And it's very difficult clinically sometimes to say, is it bacterial, is it viral, should I prescribe or not? And more often than not, as we've seen, we err on the side of caution, not knowing when we may see this patient again, to prescribe antibiotics, when in many cases it may not be required. And I think we've also not been able to, so whatever sensitivity patterns are being done in many places, we've not been able to collate the data across the MSF movement or across different hospitals, not just MSF, in the places we work, to provide this evidence back to the treating clinicians to help them decide on treatment. And again, with antibiotic stewardship coming up, there's still not enough clinical microbiologists, trained infectious disease specialists in MSF and outside in most of the countries we work who can help with the stewardship or mentorship in this direction.
Mm-hmm. Just a question of clarification. Philip, do we have a database now in MSF where we collect information from all of the different projects like we have for TB, like we have for sleeping sickness? Is that the case? We don't. So we still have much more work to be done. All right. So I'll move on to Surendra. So 6 years ago at the World Health Assembly, this was a big topic of discussion, antimicrobial resistance. What has changed in terms of awareness, in terms of action at the global level in the last 6 years?
Good question. I'll try to be very short, but let's start with the positive side. I mean, I do believe that for the past 3 years we have seen a tremendous momentum about raising awareness on antimicrobial resistance. And you've seen that from the 2 years ago in 2015, and I consider it as a milestone, where you had is that from the World Health Assembly at WHO, a resolution that pushed for first a resolution about the adoption of the Global Action Plan, which is a milestone, and secondly, recommending actually strong recommendations for countries to develop their own national action plan. It's kind of easy to say, but very difficult to do. And the condition about the action plan was to make it align with the global action. Well, it's not only a paper where you could have empty actions without interconnection between the different sectors. But this is my, so I can expand on the detail. And recently, in last year, in September, this is the first, actually not the fourth time, that we have the health issue that was brought up at the UN General Assembly, and it was about recognizing the problem of antimicrobial resistance as something that is a global threat for health security. And this, for security itself of mankind, but health security as well. And that was a tremendous advance. If you want to compare it, this was the fourth time that the issue was brought at that level. The first time was HIV, Ebola, and non-communicable diseases. So AMR is at this stage now, where it's leaders of the world know of the threat posed by antimicrobial resistance, more importantly, antibiotic resistance.
All right. So you talked about the global, first of all, there's a global will now, but also a clear will to align national programming with international priorities as well. Perhaps, Philip, you can tell us what's been happening in India. I know that the government has formulated a national action plan. Perhaps you can talk a little bit about what that action plan entails and perhaps the breadth of that plan, the reach outside just the Ministry of Health and all of the other actors involved. Thanks.
Thank you so much. I'm Dr. Philip Matthew. I'm not the director of REACT. I'm representing the head of REACT Asia Pacific.
But you're the director for us today.
Thank you.
We give you the title.
India has formulated a national action plan on antimicrobial resistance in line with the global action plan very recently. The best part about it is there is no finger pointing. Usually in all discussions about antimicrobial resistance, it's all about, you caused it and you are responsible for it and all that. But I believe, the National Action Plan India is a more progressive document. There is no finger pointing. There are some references about who is responsible and all that, but it's mostly a moving forward document, a document about how to move forward and what are the things to be done in short term, medium term, and long term. Okay. Another important thing, another important fact about work till date before the National Action Plan was formulated was all the departments or government institutions are working in all the organizations, even the civil society organizations, departments, institutions were all working in silos, totally disconnected to each other, totally compartmentalized, but probably with the coming of National Action Plan, there'll be more integration in activities. As in multiple ministries can come together and formulate kind of implementation plans together. Other things is like apart from the National Action Plan, I believe there has been a lot of overemphasis on the medical healthcare sector till date. But the National Action Plan has realized that probably we should be looking at the non-medical aspect of antibiotic use also, because as Sir was saying, almost 70% of the total antibiotic production is consumed in sectors like fisheries and animal husbandry, basically as growth promoters, not as curative components, as growth promoters. So it's high time we should be looking at that. So there is a lot of emphasis given for the farm sector, where antibiotics are being used as growth promoters. And of course, the need for integration between government departments. Civil society organizations can do up to a certain limit. We realize that if we want to take forward the message, we have to engage all the government departments, all the government ministries, all the government departments concerned, all the government institutions and the key administrators have to be on board if we want to take this message forward. I'll give you a small example how antibiotic resistance, we have been discussing antibiotic resistance for a very long time in the academic circles, but it hasn't reached the actual people who are working on the ground. Recently we had a workshop, we found out that the Kerala University of Fisheries and Ocean Studies, it's a state university for fisheries only, a specialized university for fisheries, has published around 15 articles in reputed international journals on antimicrobial resistance. But the administrative people who came for our workshop, mostly people above the rank of assistant directors, deputy or joint directors from the Department of Fisheries, had very rudimentary knowledge about antimicrobial resistance, in spite of the fact that the State Fisheries University was able to publish 15 articles in reputed international journals. That shows the disconnect between academia and the actual policymakers / administrators. So possibly the National Action Plan is a comprehensive, can give us a comprehensive platform by which we can take forward our initiatives in the field of antimicrobial resistance.
So we've talked about practice, we've talked a little bit about global will, we've talked a little bit about policy. So what we'll do is we'll take a few questions, but when I come back, I would like each of you to maybe provide 3 priorities going forward in research, in practice, in research and in policy, all right? So questions. Okay, there's one, the first. Please state your name and where you're from.
Hello.
Yeah, great.
Good morning, everybody. I have been working as a junior resident.
Your name? And
my name is Dr. Dhyan, and I have been working as a junior resident at Paras Hospital, Gurgaon. The topic here is antimicrobial resistance. I'm sorry I came late. Important issue was raised about the use of antibiotic in the viral fever. But I come from North India. An important issue was left, that use of antibiotic without any prescription.
Yeah.
If you go anywhere, I come from the small village of Varanasi. When I go to my village, there is menace of antibiotic use. Everybody using amoxicillin, everybody using Ciplox. So, do we have awareness program, number 1? And number 2, we need a strong legal action against those who are giving antibiotics, especially important ones, without any prescription. Is MSF is doing any work for legal action in India?
Thank you, and we raised that point in the last presentation, but we'll come to the legal part of it. There's another speaker there, and then Leena.
Thank you very much. I am Dr. Vikas Agrawal. I am Regional Director for Kala Azar program and also Regional Coordinator for Fleming Fund, which is looking after AMR related issues in South Asia. So my kind of comment to all the three panelists, one is that, in fact, I was having a question which you asked, that whether MSF is maintaining the data set, and I think it would be very critical to have data from the MSF site, and not only from the MSF site, but all the sites which National Action Plan is working on. But the real challenge would be to have sufficient microbiologists and data surveillance point in these centers and have the capacities. So with regard to the kind of focus, the question which you had, there is a emphasis Fleming Fund which would be supporting 30 countries on AMR through Department of Health UK. So the emphasis would be to strengthen the surveillance point and AMR resistance, data collection and analysis, and reporting into WHO net. So that's a kind of a comment.
Thank you. So far there have been no questions for the panelists. I would like you to reformulate your comments as questions. But Lena, perhaps you have a question on the legality, legal aspects that the first speaker asked.
Ask a question on the process.
Yeah.
On the AMR policy, and maybe, I shouldn't be asking you, I should be asking the government. Did they hold any regional or statewide consultations on before formulating the policy? Because the WHO has sort of given a blueprint of it, but it does need to be tweaked. And there are going to be very specific issues that are very contextual to particular areas, particular countries. Did the government do any of that? So that would be a very useful input into the future of working with the government.
Yeah.
And on the legality, we can deal with it.
We'll come back to it. So Dr. Matthew and maybe Dr. Wong can also comment on it. Yeah.
For the National Action Plan for India, like there was no regional consultations as such. As in a decentralized consultation process was not followed as far as I know, but there has been a reasonable amount of consultation which happened based in Delhi. Okay, with multiple organizations, Center for Science and Environment was involved, multiple organizations, civil society organizations, REACT was also a part of it. So there was a fair amount of consultation which happened in Delhi, but regional consultations probably, we need to work out more on that.
Thank you. I want to thank you for this question. I think it's a key question for me. There's a lot of confusion on the fact that when you look at best practices in terms of policy, when you look at overarching policies, for example, preventing the sale of antibiotics without prescription, for example, or the growth promoters. And I'm not pointing out at India, but it's a regional picture of the region, is that you may have policies, the overarching policies, but getting to the level of enforcing those policies is the major issue, with a lot of problem with governance and things like this. But the real issue is about making sure that the government is taking charge of developing country-specific policies to make sure that this overarching policy would work. And I just want to highlight this challenge that needs to be really taken care by government. And this is one of the things that we thought about. Aligning the National Action Plan with the Global Action Plan is really about making sure that you have all aspects of the Global Action Plan in the National Action Plan, and with this approach that it covers all sectors, including policies, the regulations, for example, not only having the Ministry of Health handling the National Action Plan, but having all other sectors like the agriculture part as well, but being inclusive of the civil society and, of course, NGOs and the private sectors and the manufacturing industry. So this is the comprehensive thing that we would like to promote. And within that comprehensive approach, this is one of the conditions of the alignment, is to make sure that you have a monitoring evaluation system embedded in the National Action Plan. And we see it as key to make sure that this National Action Plan is not about a document that you put on the shelves and you forget about this. It's making sure that countries now are accountable, because what I say in the National Action Plan is also about showing the gaps, but making sure also that we can measure progress.
Yeah. But Surendra, maybe I'll take the prerogative to ask a question. How does the National Action Plan, for example, very specifically address the issue of the way research and development is done, where how intellectual property and how the way innovation is structured today? How is the government trying to address that? India is known as the pharmacy of the developing world. How are we changing the discussion around drug production and research and development.
This is a question for India specifically. Yeah. Okay, I wouldn't go too much in detail, but let me get into the bigger picture of the research aspect of development. And you want to? Oh, you want to take the question?
No.
Oh, okay. I do believe that. I do believe that. Okay, I'll be very short. I do believe that the approach for development and research in India was the fact that you have very extremely good institutions that are doing research. But if you look at the bigger picture, they're all scattered, working in their own ways. And if you compare with countries that have the potential also to do an innovative approach in terms of new antibiotics or new diagnostics, for example, or other intervention, is the potential for the government to maybe coming up with an approach where you will have a capacity for those institutions to work together with the same, and I'm not saying a naive way, but more a consortium approach with these common objectives. So I try to be short in that and stop here.
So we'll take one more question and then we have to go round up the person here.
Thank you. I'm Dr. P.K. Bansal from Meerut. It's my personal experience comment. Even in the remote areas, say CSC, PSCs or small villages, we should not start the day one antibiotic empirically until the patient is critically ill or deteriorating very fast. And if it is so, the patient should be transported to the nearest multi-specialty hospital, having a facility for the culture and sensitivity, and depending on the protocol of that particular hospital, the available data regarding the microbes available, most susceptible antibiotic should be given. That is the, I think, best way. And probably we should avoid a polypharmacy or polyantibiotic therapy.
Yes. So, I mean, it's clear that the issue cannot be addressed with, we need a multi-sectoral approach. We need to approach it from the ground up all the way to the level of policy. So what I'll do is I want to come back to each of you, and perhaps you can give 2 or 3 priorities for example, Alan, as a physician, what are the 2 or 3 things that need to happen to change the game?
Yeah. I think I just want to start by saying, while we want to rationalize antibiotic usage, the thing as MSF and as all of us we want to keep in mind is we don't want to give up access to people who need it to save their lives. So it's a bit of a give and take. While ensuring people don't lose their lives because of lack of antibiotics, we need to make sure people have access to antibiotics and we rationalize use. As clinicians or as people who work with patients, I think a couple of priorities. One is definitely scaling up of stewardship programs with bacteriological lab sensitivity. Like he was saying, I don't see the point of referring to hospitals, but maybe make lab sensitivity data more available even at a peripheral level in the future, in the ideal world. Infection prevention and control is something we've not spoken much about, and hospital-acquired infections, because that's where a lot of the resistant ones spread, and something where we can improve. And the third thing I think we need as clinicians is more operational research on point-of-care tests and things, aids that can help us at the bedside of a patient to make the decision safely and effectively.
All right. So hygiene, diagnostics, and the first one?
Stewardship of bacteriology.
Thanks, Alan. Surendra, in terms of 3 sort of priorities, in terms of the research.
Research.
Yeah.
Okay, I'll put it that way as well. I mean, of course, the research is to have better diagnostics, better new antibiotics, but it's easy to say, but the challenge is huge, and I want to expand. But I wanted to raise the issue of having data. And so far, AMR is a complex issue with the combinations of different conditions, different antibiotics, not even antibiotics, but also antifungal agents or antiparasitic agents, plus the numbers of antibiotics, which makes it very difficult for us to produce data. And of course, these data are really needed for awareness and to have a better understanding from not only the population, but also the higher level on the what's at stake for it. And so far, we don't have any information on the trends. We have data from grassroots. We have some national data that shows the trend, most importantly from developed countries, but nothing from our region. And this is one of the major objectives that we need to achieve. Yeah.
Have there not been some attempts at global registries to plot resistance patterns, etc.? what success have they met with? These
Well,
sort of efforts?
it's work in progress. I mean, there are, if you, I want you to refer to this global survey that was done in 2015 and also the global surveillance report in 2014, I think. It really shows the gaps. It's just that we have a number of threats that goes from ESBL to gabapentin resistance or MRSA, vancomycin resistance. But if you look at the pictures in countries, most of those information is missing. And this needs to be taken care of. And when I'm saying missing, it's not only missing in the human health sector, but it's also in the animal sector. And looking at surveillance for consumption, but not only consumption in the human sector, but also in the animal sector. And the potential for those antibiotics resistance spread that spread through environmental contaminations. These we need data. We don't know the magnitude of the problem yet.
So, I mean, given what you said, it's heartening to see that India does have a national action plan. It has 12 ministries coming together to address this. What, according to you, are some of the things that the action plan should sort of recognize and emphasize and prioritize for the coming years?
Our National Action Plan, incidentally, is a much larger document as compared to the Global Action Plan. So, at least the document size-wise, we are better than the Global Action Plan. But seriously speaking, an intersectoral coordination, which has to, on the ground, there has to be an intersectoral coordination, and all the stakeholders has to be brought on board. Actually, we have been focusing on Ministry of Health for a very long time. Multiple countries have been focusing only on their ministries of health. But other departments, especially at least the people dealing with animal husbandry, fisheries and agriculture, and also environment, needs to come together for a reasonable outcome. Okay. Otherwise, probably it may not be possible to obtain a reasonable outcome. Second is collaboration between civil society organizations. A lot of organizations have been working very discreetly. Probably if we can come together, synergize our efforts, we can better output can be possible. And of course, genuine concerns of people engaged, like my co-panelists were saying about point of care diagnostics. In our informal discussions with health administrators, at least the southern part of India, we found out that access to point of care diagnostics, like pediatric centers being equipped with simple things like blood counts or access to a CRP, improved antibiotic prescriptions. Actually rationalized antibiotic prescriptions by a huge extent. Also, we need substitutes. People are using antibiotics as growth promoters in the farm sector. We need some substitutes because their yield is at stake. They won't be backing off without if they don't have a proper substitute. So these are things that we should be taking care of course, and research should be focusing on. There should be some emphasis of research which should probably focus on things like faster turnaround time for intensivists, because empirical therapy is wreaking havoc, at least in the hospital sector. So things like that has to be, I believe, we are running out of time, so stop.
So I'm being hounded off the stage, but I want to thank the panelists. I know we haven't had enough time to discuss all of the aspects of public response to AMR, but thank you so much for joining us, and I'll hand it over to Philip